to be specifically talking today about the integration and harmonization of diverse data resources. So the two objectives for this portion of the talk are really to define a common language for integrative data analysis, integrative data sets and their analysis, and to identify key methodologic considerations when you're designing an integrative data project. I'm going to talk about those objectives in the context of two different portions of integrative data research. One is really work that's designed to increase the breadth of the study. So to increase the diversity of a sample size across populations. This is what we generally think of as pooling multiple samples together to get a much larger representative population. But there's a new and growing trend to data linkages that Dr. Denny mentioned to really increase the depth of information we have about any individual within our population or our cohort. And so I'm going to break those two apart to talk about the kind of how-to issues that are associated with each of those study designs. So to start off, first, I'm going to talk about pooling and harmonization. And I think I would start off by saying that integrative data sets, I think, are really the future of EPI. This is really, I think, where we're going. And I'm sure you're all aware that there have been a growing number of publications which are combining multiple cohorts or bringing together multiple samples. As Dr. Denny mentioned, the field of genetics has really been leading the way in this. And that's partially because there's some key advantages to these pooling studies. The first is you obviously get a much larger sample size. So you can examine smaller effect sizes, you can examine rare outcomes without having to do a case control study, and you can really disentangle phenotypes that may be more heterogeneous than we once thought. An example of that might be heart failure with preserved ejection fraction. It's increasingly understood that there's a variety of underlying phenotypes there, which each have different pathophysiologies that lead to HFpEF. In addition, by pooling multiple cohorts together, you get a more diverse population. So you can really represent the breadth and uniqueness of different groups across the country or across the world, and you can really enable yourself to look at subgroup analyses to look at similarities or differences across those groups. And lastly, I think you also have this ability to follow individuals across the lifespan. So you can really combine cohorts in a way that allows you to get a full picture of a life course perspective for any disease and examine different trajectories in that life course perspective. And that last piece is really my particular research interest. And so if we're just taking that as an example, thinking about the life course perspective in just healthy aging, we know that the trajectory of aging actually begins very early in life, and some might argue even prenatally, and that the early differences may be influencing later patterns and disparities in healthy aging. To date, we've mostly had information from specific cohorts on one or two of these major life stages. So we've got childhood cohorts, we've got adult cohorts, and we've got older age cohorts. And more recently, we've had studies like Framingham, for example, where they've actually gone and extended across two different age periods. What we're particularly interested, though, is this full life course aspect. Can we actually understand the origins of disease and also see them play out into older ages so that we can understand these differences in trajectories? So just as an example, we have a proposal for a Lfie Course Consortium. We've been working with cohorts across the world to really create this Lfie Course perspective. And what you can see here is there's on the top are the adult cohorts and on the bottom are the childhood cohorts. The x-axis is age in years. And what we wanted to do is we wanted to pool cohorts in order to allow us to have information across the full spectrum of age, from childhood all the way to older age. And by pooling these cohorts, we can actually achieve a course perspective on how early life influences may impact later life trajectories of health. Obviously, when you're combining multiple cohorts, a large number of cohorts, there's a lot of work that has to be done. Each of these cohorts was designed and the data was collected to be independent of each other. And we're now post hoc trying to put them together into one larger sample. And so that requires a lot of harmonization. So by harmonization, what am referring to is efforts to combine the data from different sources and from different users or different studies with its own unique protocol and its own unique platforms. And what we're trying to do is combine them in a way that we can get an usable picture of what the life course of a disease is. So when you're thinking about harmonizing data, we have a couple key considerations that we have to take into account. The first question is, can we standardize and optimize the harmonization process, both scientifically but also organizationally? And we want to maintain rigor while maintaining the costs that we actually have available to us. What measures can we use to determine how successful our harmonization has been? Obviously, we can't just throw everything together and hope that it was measured in the same way. We have to have some way to evaluate the harmonization process. What's the minimal and optimal level of harmonization that's needed to ensure correct inferences? And also what levels and types of documentation are needed from collaborating studies to ensure maximum efficiency of the harmonization process. So obviously you can get all the protocols, you can get their data dictionaries, and then begins the work of actually harmonizing. So if we just look at some of the adult cohorts, these are the cohorts at the top, you can see that each one has had a variety of different examination cycles at different time periods over the course of the past 30 years. For example, this is the 3-city study. You can see their baseline was about 1999, and they had 3 follow-ups going through 2012. At the end here is Whitehall, and you can see again they started much earlier and have had many more in-person exams. So when you want to start off with harmonization, you have to start off with truly understanding the data. So it's not only the structure of the data, but at each of those exams, different information was collected in different cohorts. This is just an example of cardiovascular risk factors, and we were just trying to track which of those risk factors was collected in which study and at which time point. And so you can see that it gets very complicated very quickly, and maintaining rigorous documentation is essential for harmonization process. When we talk about harmonization, what we're talking about is a variety of different approaches. So we use different methods to actually ensure the harmonization of different types of variables based on what we can do and what we need to do to actually make scientific contributions. So what we most often see is algorithmic transformation. So that's really just kind of lining up categories. Often we see this when we're talking about the highest level of education or race, ethnicity. We're just trying to align categories that are combinable. We also often see simple calibration models and cardiovascular risk factors. This is making sure really that the units are on the same scale, that if we're going from pounds to kilos, we'll all have a consistent metric. We then often see standardizations where we see z-scores, and so we're just trying to make sure that the distribution of those items is consistent. With z-scores, we don't often have a way to back translate the absolute value. What we're doing is looking at the range and distribution. So each person is compared to other people in their same cohort across the distribution. Less often we see more latent variable constructs or multiple imputation models where we're trying to actually use statistical modeling techniques to actually harmonize data that may have been collected in very different ways, but maybe all trying to get to the same underlying latent variable, or may have been collected in different scales, but we have some way to overlap those two scales. Maybe one study collected both of those scales, and we can kind of impute across cohorts. Each of these methods is used for different types of variables and in different settings. When we apply a harmonization, we then have to evaluate how well our harmonization, whether we succeeded. And often people think you succeed in harmonization if all of the cohorts have similar values of that variable across cohorts. But what actually we need to be aware of is that that's not actually the metric of success. We expect there to be differences in many of the risk factors and many variables across cohorts, but we need to understand why those differences may exist. And we need to make sure that those differences are true differences and that they don't just represent methodologic differences across the cohorts. So in one example, we were harmonizing diet, which is actually very complicated across cohorts because it's not collected in any standardized way. And we did multiple different methods in parallel, or in sequence, I should say, to actually harmonize diet. So we had to align the types of foods that each study collected. We then had to align the serving sizes that each study collected, and then we had to do imputation. But you can see in this subset of the cohorts, what we calculated was the alternate healthy eating index. This is paneled by each of the cohorts: Eric, Cardia, CHS, Framingham, Offspring, Jackson, Mesa, and WHI. It's separated by gender for women and men. And you can see that we were looking at the means and medians. So we were comparing the distributions across the cohorts. And the distribution was similar. The means and medians were similar across the cohorts, but you'll notice there were differences. We do expect there to be cohorts that had maybe healthier eating patterns than other cohorts that may have had poorer eating patterns. But at the end of the day, the success of harmonization is that we acknowledge that there's differences in the cohorts that are not due to methodology, they're due to actual cohort differences. And so a lot of harmonization, again, is examining why you get the results you get and really understanding what their differences are. So when we're thinking about harmonizing, at the end of the day, there's two strategies for actually doing the analysis in these pooled cohorts. And so I just wanted to highlight that we can do a true pooling or combining the data together into a single cohort. This is often called integrative data analysis. It's essentially bringing all of the different cohorts together into one large cohort, sometimes a synthetic cohort, and doing the analysis as a single sample. Adjusting for or stratifying by the cohort itself. The advantages of doing it this way are that it allows you to utilize a wide variety of statistical methodologies, but it does assume that all those populations are this part of the same underlying sample. And so there's some questions about really understanding why there may be differences across cohorts, and a lot of investigation has to go into that. Another option is more federated or meta-analytic methods, in which the analyses are done on the harmonized data sets in parallel or sequentially across the cohorts. An advantage of this is that data can be harmonized in different sites around the world and then analyzed in its own home institution, and the outcomes, the effect sizes, can then be meta-analyzed together to create a larger understanding. But you must have appropriate meta-analytic techniques to be able to create that single pooled estimate if it's appropriate. And not all of our statistical methods have that meta-analytic method to combine and effect sizes. An advantage of this meta-analytic method is it intrinsically takes into account population differences. And so it's very clearly set up to understand whether there are certain samples or populations that may be different than others.